Good morning, everybody. Welcome back to Grand Rounds. We are continuing our Senior Grand Rounds series right now, actually finishing up this time. We have two fantastic speakers today. First up, we're going to start off with Dr. Eric Mittauer. Dr. Mittauer obtained his degree his bachelor's degree, in human physiology from University of Iowa. He then came here to WashU to obtain his medical degree, and then we were lucky to have him match here for residency. He plans to pursue GI fellowship in the near future. And in lines with this, he's going to give us a really interesting talk about the advances in management and actually naming of steatotic liver disease. Like I said before, we have two talks today, so please hold your questions for both talks until the very end. And please help me welcome Dr. Mittauer.
Working? Yes. Awesome. If I can get this tucked away. Alrighty, thank you all so much for coming today. I'm really excited to talk about metabolic liver disease. This is a topic that I always kind of understood in very vague terms, and I also know that there's been some big changes recently that have muddied the waters, so I'm really excited to share more about this. Before I go any further, unfortunately, neither Samrah nor I have any disclosures to discuss. And my objectives today are to really contextualize the history of our knowledge of metabolic liver disease, to talk about the recent changes made to naming and diagnostic criteria, to kind of explore the impact that it's had on patients, and then to talk about the really exciting advances in treatment options. And then hopefully inspire a passion for diagnosing and managing metabolic liver disease. So to understand why this is such a big deal, I think it's important to talk a little bit about the history of liver disease. Since the ancient times, multiple cultures thought the liver was important. They thought it was the source of emotion and willpower. The Greeks specifically really studied the liver in depth, and what they saw made sense, that the liver is the source of willpower. People who drink alcohol heavily and have corrupted willpower would have a sick liver. This kind of informed our understanding of chronic liver disease for centuries. In 1685 was the first anatomical description of liver disease in the dissection of an alcoholic soldier. They called it glandulus to the eye, which is our first real description of what we now call cirrhosis. In 1819, the French physician Linnaeus, who also gave us the stethoscope, described in another dissection of an alcoholic patient, buried way in a footnote, he describes a new term, cirrhosis, from his description of the impressive amount of fat on the liver. And then in 1857, the anatomist George Budd, who also identified Budd-Chiari disease, was the first to identify histologically that fat tissue was involved in chronic liver disease. And he called it extremely fatty in men who drink immoderately of ardent spirits. So the reason I wanted to kind of lay out this timeline is that throughout the vast majority of medical history, there was really one truth, and that's that chronic fatty liver disease was a one-to-one correlation with alcohol. There was really no other cause. Until NASH hit the scene. So Ludwig Jürgen was a pathologist who scraped together 20 cases of something that terrified him. He found patients with what appeared to be alcoholic cirrhosis, except that they didn't drink alcohol. Most of these patients had already progressed to fibrosis, and a few had full-on cirrhosis. And the only linking factor was that these patients were mostly obese and many had diabetes. He termed this disease NASH, which is a name that it would be called by for decades, and he said that we know of no effective therapy. So we've talked about 2,000 years of medical history. Metabolic liver disease came around in 1980 at the Mayo Clinic. This was the first time anybody had ever seen this. So I think there's an idea that metabolic liver disease is this centuries-old thing that's always been there, but we've only known about it for as long as we've known about Pac-Man and the Rubik's Cube. It continued to grow pretty quickly. In 1986, a review article coined MASLD, which was another name it would be known by. And then 1988 was a seminal year. Dr. Anna Deal, who's a gastroenterologist who still practices at Duke, was the first to describe the MASLD population. She got together 300 patients and was the first to critically characterize the population of this disease. So she found that these patients overwhelmingly are obese, diabetic, hypertensive, and have cardiovascular disease. Today, these are things that we know as metabolic syndrome. And what terrified her was that 1/3 of these patients have advanced fibrosis or cirrhosis. And I think it's really important to keep in mind that in just 8 years, metabolic liver disease went from a histologic novelty to something with such clinical relevance that there were entire labs devoted to it. So before I go any further, just kind of refreshing on what this liver disease is. At its root, it's pretty simple. Fat is deposited in the liver. That fat produces inflammation, and that inflammation produces scarring. In other words, steatosis produces hepatitis, produces fibrosis. This is the exact process that happens in chronic alcohol-related liver disease. What's different is the physiologic level. So metabolic liver disease is characterized universally by insulin resistance and dysregulated lipid metabolism, which is the same things that happen in other metabolic syndromes. What's key about metabolic liver disease is that it's incredibly heterogeneous. Every patient is unique in the exact combination of causes that led them to develop MASLD. And what's really essential is how comorbid this disease is with the other metabolic syndromes, and not only comorbid with, but actually synergistic with a lot of these processes. So we talked about how this really came out of the woodwork in 1980, so we have to ask ourselves, why did we miss this for so long? Is it possible that this was always there and we missed it? Did hepatologists just decide their clinics weren't booked out far enough? I want to lay out a different theory. So this is a really interesting graph I found that laid dietary badness along the US obesity rate. And if you look where the inflection rate on the US obesity rate occurs, it's right around 1980 where this disease was first discovered. So we know that scarring and cirrhosis requires persistent, repetitive trauma to the liver. And for most of human history, alcohol was the only way to achieve that. And it's only in the last 70 years that our diets have become bad enough that we can do this with diet alone. So that's a little bit about how we got to this point. I want to talk now about some of the naming changes that have happened. And I do want to give credit. A lot of this, basically the rest of my presentation is adapted in some form from the AASLD guidelines that were laid out in 2023. I really encourage everybody to look at these. They publish 2 papers, each are 10 pages or less in very simple language, and they basically summarize everything we know about diagnosing and treating metabolic liver disease. So really this all stemmed from a 2023 study that multiple liver bodies did of their own members, and they found that 74% felt that an immediate name change was warranted to NAFLD, and that's a pretty impressive rate of concordance for academic physicians. The key reasons they felt this change was important, one was that it was stigmatizing. Fatty liver is a loaded term, especially since we now know that a portion of these patients aren't actually obese. It was incomplete. Most of the respondents felt that any name should include metabolic. And it's weird to call something by what it isn't. You can imagine how weird it would be if it was A1AT and non-A1AT COPD. And finally, it's really just considered to be inaccurate. By definition, non-alcoholic fatty liver disease shouldn't include alcohol, but what we now know is that it's really a spectrum of disease. So I know there's been a lot of consternation. Here's, in very simple terms, the new terminology for metabolic liver disease. The umbrella term is now steatotic liver disease, which is when fat makes up greater than 5% of the liver by weight. We'll talk about how this is diagnosed in a little bit. Some of these patients, what was previously called NAFLD, is now MASLD, or metabolic-associated steatotic liver disease. And this is SLD with one of 5 cardiometabolic risk factors that we'll discuss in just a little bit. And then a small portion of these patients will go on to develop what was previously NASH, but is now known as MASH, or metabolic-associated steatohepatitis, which is liver fat deposition with the presence of inflammation on pathology. So this is really the new algorithm for fatty liver disease, and you can see the branch point is this cardiometabolic criteria. They've included here, you can see this is the adult criteria, and tragically there's actually a pediatric criteria as well. But to sum it up, it's patients with liver fat who are obese, diabetic, hypertensive, and with some form of high cholesterol. Most of you will probably see a patient today that meets these criteria. And I'm not going to ask for a show of hands, but I want you guys to think to yourself if you've ever put personally a diagnosis of metabolic liver disease in a patient's chart. If you haven't, you're in good company. A really interesting study in Europe in 2018 surveyed 18 million patient charts and found that 1% carried a chart diagnosis of metabolic liver disease. And as we'll discuss, that is a massive underdiagnosis. A little bit more about terminology. The first thing is that what was previously alcoholic liver disease, like alcoholic cirrhosis, the preferred term is now alcohol-associated liver disease. In addition to being less stigmatizing, it's also more accurate. Some patients with alcohol-associated cirrhosis haven't drank alcohol in 20 years. And then I want to lay one more term out for you guys. I talked about how this is really recognized to be a spectrum now. With one end, we have the metabolic chronic liver diseases, and on the other end, we have alcohol-related. but we're now realizing there's this middle ground. So the new term is MASLD, which is patients with both cardiometabolic risk factors and alcohol use. And this was felt to be important. You'll see these if you have patients who have hepatologists in their chart, because we know that these patients especially have devastating outcomes related to each form individually. So that's the new terminology, and I want to talk a little bit about why this is such a big deal. As far as why we should care about these fancy new terms, I think this graph speaks for itself. This is MASLD rates specifically, and you can see this is a global epidemic. It doesn't discriminate by country of origin, race, economic factors. It is basically everywhere. This chart kind of lays out the progression from healthy liver to fat deposition to inflammation to scarring. And what I really like about this graph is the directions of the arrows. You can see that every step up until cirrhosis is reversible, which is really why it's so important that we be able to recognize these patients before they reach cirrhosis. So to talk about some numbers, as we showed, about a third of patients in their lives will develop metabolic liver disease. A further 20% will develop inflammation consistent with MASH, and a further 20% will develop fibrosis and potentially cirrhosis. If you're like me and you're not good at quick mental math, to cut to the chase, that's an estimated population of 6% of the world with MASH and 1.3% with cirrhosis. To project to the US, that's 22 million people with MASH and 4.3 million people with cirrhosis. This was a terrifying and interesting graph I found that took historical estimates of MASLD prevalence and forecasted them out. You can agree that this is not exactly an aggressive trend, and you can see that by 2040, it's estimated that greater than half of patients we see will meet criteria for metabolic liver disease. We should care about this because it's a big deal, in short. It's the most common cause of cirrhosis in the developed world, and it's the fastest growing cause of liver transplant in the US and expected to become #1 by 2030. This should scare people because these are not great transplant candidates. They're older, they're sicker, and they have worse outcomes, probably for the above reasons. Something else that makes these patients unique is that with alcohol-related liver disease, when you transplant, you can stop that liver irritation overnight by quitting drinking. The same is not true for metabolic liver disease. There's no 12-step program that lets us rewire our metabolism. And setting the liver aside, these patients are inflammatory and have drastically elevated all-cause and especially cardiovascular mortality. So financial costs, it's estimated at greater than $100 billion per year. Per the NIH, that's the same as breast, prostate, lung, and colorectal cancer combined. One really interesting study looked at Medicare utilization rates of these patients and found that they have vastly increased costs. They also see outpatient visits much more, and if you're breathing a sigh of relief because you're not a liver specialist, only a fraction of these visits were to liver specialists, with the vast majority being an increase in primary care visits. So that's a little bit about why we should care so much about this. So I want to talk about how we diagnose this disease. Historically, the gold standard was biopsy. Percutaneous, transjugular, and now transesophageal were all options. This can also be done through MRI. That said, we're talking about a third of the world meeting this criteria, and I have a hard time getting my clinic patients to take their flu shots. So clearly, this is not an appropriate solution. So I want to talk about something we'll all see a lot more about in the future, which is transient elastography or fibroscanning. This is an ultrasound-based modality to study the stiffness of the liver, and it looks something like this. It gives us two measurements, the CAP, which measures fat deposition, and LSM, which measures fibrosis. These are both really important prognostic factors, and previously they could only be found with biopsy. The readout looks something like this, and it gives you you take 10 measurements, and about 5 of them are required to be accurate to have a successful read. And I want to talk a little bit about the interpretation, since I think we'll be seeing these more in the future. This is already standard of care in the hepatology clinics. So we have these 2 measurements, and the scoring looks something like this. So in this particular patient, you can see that they have a moderate amount of fat deposition, but actually have severe F4 fibrosis consistent with cirrhosis. So again, these are important prognostic factors that before could only be established with biopsy. The benefits of this are obvious, a fraction of the price, a fraction of the risk, and actually gives us a much greater look at what can be a very heterogeneous disease. There are some limitations. They're getting better all the time, but early studies on this found that they did have some operator-dependent limitations, as well as some patient-specific limitations. Elevated BMI was one of the big ones. It's obvious why that's a drawback in this population. And then it's also limited in specific disease processes like inflammation and congestion. That said, this is now becoming standard of care, especially in the hepatology world. So the question becomes how we're going to deploy this. For years, this is about a 10-year-old technology, and for years there was no clear guidelines for how this should be utilized. Just in the last year with these 2023 MASLD guidelines, we now have the first proposals for how these should be deployed. What we should know first is that this is not going to be used for population screening. This is not the new colonoscopy or mammography. The AASLD, the liver body, released this beautifully detailed algorithm. It's got a ton of great detail, and it looks a little bit like a New York City subway map. So I'm going to jump over to the end, some guidelines they put out in relation with some endocrine bodies who apparently have better graphic designers. So their proposal for how this should be deployed is in the primary care setting. Patients on the right that meet criteria for metabolic liver disease would enter a fibrosis risk stratification. The proposal is that this would use the FIB-4 score. This was devised in 2006 to estimate fibrosis risk in viral hepatitis, but has actually been pretty well validated in metabolic liver disease. It uses some very easily obtained factors and can be calculated in 10 seconds on MD-Calc. The proposal is that patients in the primary care setting would be differentiated according to their risk. High-risk patients would go directly to a hepatologist, have biopsies, and be treated there. Low-risk patients would stay in the primary care setting and be managed there. And then patients found to be intermediate risk using their FIB-4 would then be screened using elastography to stratify their risk. This is a little more from the previous graph about specifically the role of primary care in these patients. I know PCPs are already overworked and they're probably not super excited to manage an entirely new disease process. But right now the hepatology clinics are chock full of patients with stable MASLD coming once a year for unchanged fibro scans. So I don't know if any of you have tried to have your patient see a hepatologist recently. You can gestate a human being in the time it takes to get a patient in with them. So I think if we want our patients to be able to keep seeing hepatologists, we need to become more comfortable in general medicine talking about this disease. So that's a little bit about diagnosis, and I want to get to management of metabolic liver disease because there's been some really exciting updates in the last few years. The first and really the standard of care treatment is weight loss, specifically 7 to 10% of body mass. I know nobody's going to be super excited about just talking about lifestyle changes, but I think it's important that we talk about how strong the evidence is for this. There's been two major papers, both published in 2015, that had concurrent results. They found that some body weight loss improved the steatohepatitis, the inflammation, and then a greater amount of body weight loss not only resolved inflammation, but actually took away some of the liver fat and scarring. So that kind of dichotomy between functional inflammation and morphologic fat and scarring is a key part of how we evaluate treatments for this disease, and lifestyle changes meet both criteria. So to kind of sum up, these patients, some weight loss improves liver function, and more weight loss actually improves the liver morphology. So for that reason, we're kind of failing our patients if we're not hammering this at every visit. Something I do want to note very strongly with the new guidelines is that we should not be limiting protein intake. Historically, the thought was that protein breakdown creates ammonia, and ammonia creates hepatic encephalopathy. Our understanding of that is a little bit more nuanced now, but what we do know is that sarcopenia hits MASLD patients especially hard, and it's a devastating, catastrophic outcome for these patients. So talk about caloric deficit, talk about minimizing carbohydrates and sugars, but don't limit protein intake. Weight loss is one thing, but obviously pharmacology is going to be an important part of how we treat this. There are dozens of pathways that play a role in metabolic liver disease, and so there's dozens of drugs that are being trialed. I want to talk about a few of the most exciting ones today. So the first one is resmetirom, and this is a huge deal. This is the first ever FDA-approved treatment for metabolic liver disease and MASH specifically, and it was approved just a few months ago. This is a liver-directed thyroid receptor agonist that's a mediator of lipid metabolism that's known to play a role in MASLD, and it was based off the Maestro-NASH trial. This was a 5-year phase 3 trial, and after just 1 year, the results were impressive enough that this was approved by the FDA. So you can see again both improvement in the NASH, the inflammation of the liver, but also improvement in the underlying fibrosis. Now, again, this is the 1 year point of a 5-year trial, so the long-term safety and efficacy are unclear. And the cost is a little eye-watering. GoodRx gave me a $500 monthly discount and only made it $4,000 a month. So clearly this is not going to be something we're giving to every patient. Something Dr. Fleckenstein wanted me to point out specifically is that this is only FDA approved for MASH, not cirrhosis. Right now, the majority of metabolic liver disease patients are reaching hepatologists when they've already progressed to cirrhosis. So this highlights the need for us to be able to identify and screen these patients. So a long ways to go on resmetirom, but it's a very promising, exciting drug. Nobody's going to be surprised that we're talking about GLP-1s today, but I want to talk about how exciting the evidence is. This really all started with the LEAD trial in 2009, which actually studied diabetes, but in their secondary endpoint analysis, they saw a massive improvement in liver function and underlying fat. They spun off their own trial from it, the LEAN trial studying metabolic liver disease, and what they found was impressive. 40% of patients had resolution of inflammation, and a fraction of patients progressed to cirrhosis. What I really want to make the point of in GLP-1s is that this is not just because of weight loss alone. There's actually a multitude of pleiotropic effects, dozens of pathways that are acted on by GLP-1s that improve this in patients. Another important factor is that for the most part, the studies on this have shown improvements in the liver inflammation, but actually didn't show any improvement in underlying liver fat or scarring. And that was true when I was making this presentation until about a month ago. The Synergy NASH trial was published in June, studying tirzepatide in patients, and the results were incredibly promising. So we see a mostly dose-dependent but very impressive improvement in resolution of inflammation and a decrease in progression of fibrosis. And then for the first time, we saw actually this turning back the time, taking away the fat and scarring that characterizes this disease. So to nobody's surprise, GLP-1s are going to play a big part in management of this disease. I wanted to talk today especially about statins based on the newest guidelines, and I've made it this far without a clinical vignette, so I'm going to divert for a second. Let's imagine we have a Mr. Stewart O. hepatitis who's admitted for a COPD exacerbation. He was a perfectly healthy guy until he saw his PCP this year, and suddenly he has all these new diseases and new drugs. When you're admitting him for a COPD exacerbation, you see he suddenly has some new LFT elevations. He has a very good hospitalist who looks at the obvious suspects. Right upper quadrant ultrasound has some fat deposition, but otherwise nothing exciting. He has a very, very good hospitalist. They take a look at his drug list, and they see that he's had atorvastatins added in the last year. I'm not going to put words in anybody's mouth, but historically, what do you guys think happens to this atorvastatin in these cases? I would propose that it goes something like this. So I wanted to talk about this and first run the numbers on statins and liver injury. About 1 in 100 patients that start a statin will have benign LFT elevations. The vast majority of these will resolve within a year. 1 in 100,000 will have a drug-induced liver injury, and 1 in 1 million will have a true acute liver failure. To compare that, we have 1 in 3 patients worldwide meeting criteria for metabolic liver disease. For obvious reasons in this patient population, there's not been a lot of robust randomized control trials, but what we see is compelling. Use of statins in metabolic liver disease reduces MASH and cirrhosis progression, and also a reduced risk of hepatocellular carcinoma, which is one of the most devastating outcomes. Setting aside the liver entirely, we also have to remember that the #1 cause of death in these patients is cardiovascular disease. They have metabolic syndrome. So what we're seeing is that patients aren't getting these enough. Right now, less than 50% of metabolic liver disease patients are actually on a statin, probably for the reasons similar to the clinical trial we discussed. And then just like the GLP-1s, this is not just a lipid modifying effect. There's a number of pleiotropic upstream and downstream pathways that improve metabolic liver disease in statins. Those are the big drugs I wanted to talk about, but I'm going to briefly touch on a few more. Metformin is something that makes sense in theory, and unfortunately the evidence just hasn't held up. It doesn't seem to be the answer in these patients. Pioglitazones have also been studied heavily. We've seen mixed efficacy, but while markers improve, morphology doesn't seem to. And then this year there was a really cool trial by an endocrinologic society in diabetic patients specifically, comparing SGLT2s, DPP4s, and thiazolidinediones. They see increased improvement in liver function, and SGLT2 inhibitors specifically had superior liver outcomes. That's improvement in fibrosis and scarring and decreased rates of cirrhosis. This was just in diabetic patients, but I want to circle back to talking about how characteristic this disease's interactions with other metabolic syndromes is. We treat hypertension differently in patients with certain risk factors, diabetes, hypertension, and I think we'll be seeing the same thing in metabolic liver disease over the next few decades, that metabolic liver disease's specific interactions with other metabolic syndromes will influence how we treat those patients. So to summarize, this is still an evolving field. You can see our rate of research has exploded over the last few years. The 2023 guidelines are the first real kind of comprehensive assessment of our knowledge and practice of this disease, but things are going to look very different in the next few decades. So to kind of leave you with some closing thoughts, this really is a new disease, and it's exploding at a rate that nobody in medicine is ready for. As frustrating as the new changes in nomenclature are, they really do reflect our best understanding of the disease and help us both consider and diagnose metabolic liver disease in patients. What we know about how to treat this is hugely exciting. Just in the last few years, we now have treatments that are becoming standard of care, and the future looks only more bright. And then kind of the final thought I want to leave you guys with is that this is not a hepatologist disease any more than diabetes is an endocrinologist disease. I promised you a look forward, and I think the look forward is this. We will all be managing metabolic liver disease in the general internal medicine, primary care, endocrinology. This is not a hepatologist disease, and we should all keep our eyes close on the horizon for the exciting advances that are coming. That kind of summarizes my talk today. Thank you all so much for coming. Thanks to the chief residents, Dr. Chang and Dr. Fraser, for their leadership, and thanks to Dr. Fleckenstein for giving me some feedback on the finer points of the presentation. Thanks. Yes.
Right. Thank you so much, Dr. Mittauer. That was fantastic. Next, we have Dr. Samrah Razi. Dr. Razi attained her medical degree from Aga Khan Medical College in Karachi, Pakistan. After that, she went up north to the Mayo Clinic to do a year of research in infectious disease, and then she came here to join us for our residency program. Her passion lies in pulmonology and critical care medicine, and she's currently applying for fellowship in Pulm Crit. Today, she will be taking us through a history of critical care medicine. So please help me welcome Dr. Razi to Grand Rounds.
Hi, this is working. Okay. Hi, everyone. I'm Samrah. I'm a PGY3 at WashU, and I'll be taking you through the history of critical care medicine. I just wanted to start by saying it's an honor and a privilege to be on this side of the podium instead of where I usually am. So a little bit about myself. I'm originally from Karachi, Pakistan. This is my medical school, Khan University, where I met my husband, who's a surgery resident at Emory in Atlanta. So I spent a lot of time going back and forth between St. Louis and Atlanta. This is my fur baby, Muffin, who also moved with me from Pakistan. And that is a picture of me skydiving, which is one of the more fun things I've done in the past few years. Two things I really like to do in St. Louis. So this cow soy from Mi Yu Thai Eatery is one of my favorite things to eat in St. Louis. I highly recommend. That is the boxing gym. I started going there last year. Oscar Ahudsi is a former MMA fighter. He teaches there, and obviously I do not go to his classes, but his partner is also a very good teacher for beginners. Sadly, Eric and I do not have any disclosures yet. So the objectives for my talk are briefly going over the chronological events of the conception of critical care medicine, discussing a few landmark trials specifically for residents, and then what areas we can continue to grow on. So let's go back to 1854. Florence Nightingale took care of British soldiers in the Crimean War in Constantinople. And this is one of the first times in history that someone thought that it's probably a good idea to give closer attention to patients who are sicker. She moved patients who were sicker closer to the nursing station, and people noticed that this led to an improvement in outcomes. This painting is currently located in an art gallery in India. It's called The Lady with the Lamp, and this shows her taking care of those soldiers. In 1923, Dr. Walter Dandy, who was a student of Dr. Harvey Cushing, the neurosurgeon who did a lot of work on Cushing syndrome and described it for the first time, he established the first 3-bed ICU at Johns Hopkins, which he made to take care of his post-op neurosurgical patients. And then this concept was later used in World War II to make shock units for the initial care of wounded and post-op soldiers. And people started giving more attention to critically ill patients in terms of doctor to patient ratio and nursing to patient ratio. So in the 20s and 50s, this shift in caring for sicker patients in a different way led to a shift in economic and social priorities, but then giving more nursing care to a few patients became a challenge. So this led to the development of private duty nursing, and initially patients or their families had to pay out of pocket for this private duty nursing. At the same time, hospice wards started developing. That's a different conversation. So just to touch on it briefly, they were ward rooms that were made for patients who were reaching the end of life, so that there was they distinguished between patients who were sick and needed more nursing care, patients who were sick and reaching the end of life, and patients who were moderately ill and in wards. And often 40 to 50 of those ward patients would just be kind of clumped together. In 1952 to 1953, the Copenhagen polio epidemic happened, and that's where a lot of the modern ventilation concepts came from. So as we all know, polio led to respiratory and bulbar failure and a pooling of secretions. The mortality rate in Copenhagen from polio was about 85 to 90% at the start of the epidemic. And at one point, about 70 patients were suffocating or drowning in their own secretions in some of the big hospitals. One particular hospital, Blegum Hospital in Copenhagen, had an anesthesiologist called Dr. Bjørn Ibsen, who did a lot of work on positive pressure ventilation and is called one of the first fathers of ICU care. He set up the first ICU in Europe, and at that time, the only form of ventilation that was known was negative pressure ventilation, and we'll talk about that in just a bit. So this is a Curis shelf ventilator. This is a negative pressure ventilator. This is the iron lung, which you guys have probably heard about recently because Paul Alexander, the last person on the iron lung, recently passed away. So these are both negative pressure ventilators. What that means, to put it simply, is that they are chambers that create subatmospheric pressure, which in a way you could think about it as pulling on your diaphragm and pulling your chest wide open so that ambient air just goes inside. As you can imagine, you don't have a lot of control over your minute ventilation and oxygenation, but there's absolutely no control over airway protection and secretions, which was one of the biggest problems in polio. So Dr. Ibsen thought about using tracheostomies because tracheostomies had been used for 4 years before this in Copenhagen, but there was little to no benefit in outcomes. He started with a 12-year-old girl. He performed a tracheostomy and then started handbagging her, and she survived. So then a whole dedicated ward was set up with 1-to-1 nurse-to-patient ratio. I wanted to include a snippet from Dr. Ibsen's paper where he essentially would have, he either did a postmortem or he had these patients, and he just played around with ventilation and CO2. And the things he's described are really interesting to me because these are things that are pretty much common knowledge now. But he was one of the first people to talk about it. So he is talking about how underventilation gave rise to CO2 accumulation, even when full oxygenation of the blood was maintained with pure oxygen. And then at the end, he realizes that when someone's CO2 is built up, you can remove their blood, drop their CO2 levels, and then he's saying the patient became warm, dry, and pink, a condition which made an anesthesiologist happy. So how did physicians respond? Now that Dr. Ibsen realized you could do tracheostomies hand-bag patients, for weeks, 316 patients were hand-ventilated via tracheostomies by 1,000 medical and dental students. So every day, 250 medical students worked with about 40 fully licensed physicians. They were paid 1.5 pounds per shift to sit with these patients and hand-bag them. I did some rough math. It may not be correct because math is not my strongest suit, but inflation adjusted, it probably is about $68 today. Because of these interventions, the mortality rate from polio went from 80% to approximately 40%. And this is a picture of those medical students. They're not only handbagging these patients, they're also playing with them and reading to them. So further advances, within the same epidemic, physical therapists started working with patients because a lot of these patients went on to requiring long-term ventilation. And ABGs were invented, and people started realizing that high-quality ICU care comes from good teamwork. In 1955 to 67, a bunch of other ICUs started opening up across the country and across the world. I won't talk about all of these, but really Dr. Peter Saffer and Dr. Max Harry Wiles set up 24/7 coverage ICUs in Baltimore City Hospital and in LA. Dr. Peter Samrah is someone I wanted to briefly discuss. He was the chair of the Department of Anesthesia at Baltimore City Hospital, later went on to work at the University of Pittsburgh. He is the one who worked with Dr. James Elm and developed CPR. So the head tilt, chin lift maneuver, mouth to mouth. It's really interesting that when mouth to mouth was discovered, they would paralyze human subjects and then practice on them and realize that even blowing your own air into someone can be beneficial. And then he also introduced the concept that lay people can perform CPR too. He wrote the book of the ABCs of CPR, which were airway breathing and chest compressions in the 50s, and then the AHA adopted this in 1973. He also started the first ICU training program. In 1966, he lost his daughter at the age of 12 to an asthma attack because of delayed access to care. So then he set up Freedom House Enterprise Ambulance Service, which is one of the first ambulance services in the US. And he worked on EMT education, disaster relief. He also employed African Americans who were deemed unemployable at the time. He was awarded the Cross of Honor by Austria. He was an Austrian physician, and he was nominated 3 times for the Nobel Prize in Medicine. This is just something really interesting I found when I was reading up about Dr. Samrah. So he worked with a Russian doll maker to make the first CPR mannequin because they realized that paralyzing human subjects is probably not the best way to practice CPR. So in the 1880s, a young woman's body was found in the Seine River in Paris, and many suspected that she died by suicide. Her beauty was considered bewitching, so a mortician created a death mask, and authorities displayed it in the hopes that they would be able to identify her and find her family, but no one ever did. So she became known as the unknown woman of the Seine, and she was, for some reason, considered a morbid treasure among art collectors. And this doll maker that Dr. Samrah contacted, his parents had a picture of her in their house, and he looked at it and he decided to make the mannequin look like her, and we still use this mannequin. And another interesting thing I found is that the song Smooth Criminal by Michael Jackson, where he says, "Annie, are you okay?" He's talking about this mannequin, like the whole concept of Resusci Annie. So in the 70s to 2010s, a lot of other big things happened. The Society of Critical Care Medicine was made. The American Board of Medical Specialties started recognizing critical care medicine as a separate subspecialty. In 1988, the American College of CCM was made. In 1991, sepsis was defined. And then in the 2000s, telemedicine started. ARDSNet trial came out, and the Surviving Sepsis campaign came out, which we'll talk about. In 2010, as we all know, the COVID-19 pandemic happened, and Merriam-Webster introduced the word intensivist in the dictionary. I know this was a really challenging time for not just critical care physicians, but all healthcare workers and all of humanity. So I wanted to focus a little bit more on what positive things we learned from this experience. So what did we learn? We learned how to use the resources we already have more effectively. That's a picture of how they used 1 ventilator to ventilate 2 patients because we ran out of enough ventilators. We also started thinking about post-ICU care syndrome a lot because we realized that once patients get out of the ICU, they have a lot of muscle weakness and a lot of other comorbidities that come out of it, and we started doing more research on that. We started triaging patients more effectively. We expanded our ICU bed capacity. We provided better end-of-life care and started taking care of ourselves better. We also restructured multidisciplinary rounds. We expanded the staffing pool in ICUs, and then there was a huge wave of digital transformation in medicine. So changes in evidence-based practices, this section is more for the residents. I didn't have enough time to talk about all the landmark trials, so I wanted to briefly go over some of the big landmark trials and one point you can take away from those. So the Surviving Sepsis campaign, in 2001, Dr. Rivers came up with the OG, like early goal-directed therapy article, where he basically said that you should give fluids and inotropes and maintain a CVP of 8 to 12, which is your central venous pressure, and a MAP of 65 to 90. And he said that this led to less in-hospital mortality. From 2014 to 2015, a bunch of other trials were done. Arise trial, process investigators did a study, and they said this does not really improve in-hospital mortality or all-cause mortality. So let's fast forward to the most recent surviving sepsis guidelines. The two big things to take away from that for residents are the strongest recommendations are to start antibiotics within the hour when it's probable or definite sepsis, and to use vasopressors to maintain your MAP greater than 65, and your vasopressor of choice will be levo. There's a weaker recommendation for fluids, and that's 30 ml per kg of fluid within the first few hours. The next big trial that came out was ARDS-NET in 2000, and it basically said that high tidal volume contributes to lung injury and acute hypoxemic respiratory failure. So what does that mean? That means using 6 ml per kg of predicted body weight tidal volume and a plateau pressure of 30 centimeters of water, because that decreased mortality and increased the number of days without ventilator use. Sedation is something that we have come a long way with. In 1995, the concept was that patients should rest. The more you sedate them, the less likely they are to have PTSD after ICU stays. So we used to use midazolam or probe for short-term and lorazepam for longer-term sedation. Then in 2002, the SAG guidelines came out, and they said there's PTSD with light sedation, but they did talk about taking sedation breaks and decreasing the time on the ventilator. They still recommended using benzodiazepines. In 2013, there was a big shift away from this mindset when the PAD guidelines came out. They said that light sedation leads to less PTSD. They said that we should not sedate patients, we should treat their pain intermittently, and then if they need sedation after that for other reasons, then we can sedate them. They recommended using Precedex or propofol instead of benzodiazepines. They also recommended daily sedation breaks and spontaneous breathing trials, which were shown to improve outcomes. Then in 2013, the same year, the ICU Liberation Bundle was made in an effort to help people implement the PAD guidelines. And this has been studied in over 25,000 patients and has been shown to improve clinical outcomes. In 2018, the PADIS guidelines came out, and they basically said similar things: use light sedation. They recommended using propofol in the CCU and propofol or Precedex in the MICU and SICU. And then a bunch of clinical trials have happened in the past few years, SPICE-3, MENDS-2, non-SEDA trials, and they've all shown that no sedation versus light sedation or Precedex versus propofol doesn't really affect your outcomes. The only caveat to this is the COVID-19 pandemic reminded us that we can't always have less sedation. There are situations in which you have to use a strong amount of sedation, in severe ARDS where you have to paralyze and prone patients, if patients are dysynchronous with the vents, and there's a bunch of other indications. But in general, we try to not sedate patients when we can, or sedate them less when we can. These are the old ventilators, and the one on the far right is actually the Emerson pressure cooker ventilator. Dr. Emerson made this in his backyard from using equipment like copper pipe tubing, vacuum cleaner, and washing machine parts, and it was used for a while before the first commercially available ventilator came out. And during the Vietnam War, it was used by military surgeons and anesthesiologists. This slide is just for Dr. Chang. This is one of the first dialysis machines that came out in 1943, and in the Korean War in the 50s, rat-borne hantavirus infected soldiers and civilians, and it led to hemorrhagic fever, renal failure, and this machine was used often. So where can we go from here? Now, this is coming from a person who hasn't actually done critical care medicine, so this is just from what I read and what I think that we have progressed in from the past, and things that we can continue to work on and that I want to continue to work on when I am practicing. So I heard this talk by a pediatric ICU attending who said that the only way we can see how we can grow is to think about the things that we've already improved on. So there's been a less is more shift in the ICU. We use lung protective ventilation, we have lower MAP goals, we use less sedation, we keep patients comfortable, not comatose. There's a huge culture of quality improvement in critical care medicine. There used to be a see one, do one, teach one approach. There weren't always attendings in the ICU with residents, but it's not like that anymore. We also have a lot of care bundles in the ICU. We have care bundles for ARDS, sepsis, sedation, ventilator-associated pneumonia. So we have these bundles that remind ICU physicians how to provide good quality care and do what we do, but do it better. The ventilators we have also improved. So now inspiration can be triggered by a patient just with a subtle change in flow, which is more comfortable than our conventional ventilators, and it means we can use less sedation to keep them comfortable. There's also a lot of big data coming out and better basic cellular processes research, so we have better informed evidence-based care. How can we continue to grow also means that we are thinking more about how to take better care of patients and their families, but also taking better care of ourselves. The term burnout came out in the 1970s, but it wasn't talked about in PCCM literature until 1995. We now try to do things like debriefing after difficult codes and situations in the ICU. We practice mindfulness, relaxation techniques, and the GME departments across the world focus on employee wellness. We also have started to think a lot about what happens to our patients once they leave the ICU, trying to focus more on quality of survival rather than the rate of survival. I wanted to end by talking about the death of George Washington in 1799. There's a lot of controversy surrounding his death. I actually found a research article that was talking about this. He was 67 years old, and he was riding a horse in the snow, and he ended up getting fulminant acute epiglottitis, asphyxiated, and died within 24 hours. But in his last day, he had 3 physicians phlebotomize him of 2.5 liters of blood. Now, that may sound weird to you, but that was one of the treatments that was routinely practiced in the time for a wide variety of ailments since the time of ancient Egyptians. This was a practice that was done and was thought to benefit different diseases. And he encouraged this himself. So the point of me bringing this up is not to criticize the physicians that took care of him. It's to just say that we should pause and think about how we've come such a long way. It might seem weird to us, but 60 years or 70 years or 100 years later, when someone is giving the same talk I am, they're probably gonna be saying the same thing about what we're doing today. And it just makes me think about how medicine evolves and how much progress we have made. And this is just one of the reasons that I love medicine, and I love reading about the history of medicine. So that's all. Thank you to the chiefs, to all my mentors, to Dr. Fraser, Dr. Chang. That's all, folks.
Were both terrific talks. So maybe I'll start with a liver question. So do you see, primary care doctors potentially doing fibroscans in their office and using that as a tool, or is that something that's going to be reserved for only subspecialists?
Let me say, yeah. So that's a really great question. And kind of what's been seen is that patients, once they progress to the cirrhosis, it's too late for us to have an intervention. So we can't wait until they get to a hepatologist. So the guidelines that were put out really suggest using that FIB-4 score to stratify patients within the primary care setting. And that's something where they're suggesting we deploy FibroScan to look at those patients with the intermediate risk factors. So I think it really is going to be something that's in the primary care setting that we're using this FibroScan. Again, it's a new technology in the last 10 years, but it's already standard of care in the hepatology setting, and I think it'll grow to be in the primary care setting as well.
Questions? Marty?
So I might have been one of those hospitals that stopped the statin on these patients. And so is there any guidance from any of the newer guidelines about when we actually should consider holding, or is it really just
Can you repeat the question too?
Yes, it's a really great question. What does the guidelines say on stopping statins? And unfortunately, in these new 2023 guidelines, there's really no concrete evidence, which is why I stopped shy of suggesting anything in my slide. What we know is that statin liver injury is maybe a little bit overblown, and at the same time, patients with metabolic liver disease really do benefit from statins. I think it's going to be in the next 5 to 10 years that we really see concrete guidelines on when to and when not to stop. But what we know now is that these patients do need statins, and we don't know exactly how that should be used in decision making. It's a really good question.
So in terms of the history of pulmonary critical care, do you think that the difficulty in doing large randomized controlled clinical trials has limited the evolution of evidence-based medicine, and what could we do to try to advance clinical research in critical care settings?
I do think that that has been a big part. I was reading about how in the pandemic they started to approve trials faster, but I think it's a challenging thing to do. So one thing we have done is try to expedite IRBs, but it's really hard to do trials in the ICU, especially when you have a gold standard. But I think the one thing we can do is try to just have faster IRBs and yeah.
Any other questions? If not, thank you both very much.